Well, good morning and welcome to the second half of the ventilator. We're going to talk a little bit today about the types of breaths we have, how they're delivered, a little bit about alarms, a little bit about apnea backup, things along that line, and then the last slide is actually your assignment for today, so it should be kind of fun. When we talk about breaths, we're talking about three sequences of breath. One is your CMV, which are all mandatory breaths, and you have full support. CSV, all spontaneous breaths, literally no support for the most part. Where support comes in is if we're talking about pressure support that goes with your spontaneous breaths on CPAP at this point. And then IMV, this is where the breaths are mandatory or spontaneous. Remember, the patient can take their own breaths in between the different machine breaths. So now we're going to talk about modes of ventilation. Remember, we've talked a little bit about those. You have control that used to be on the machines, assist control. We used to have a lot of IMV. Now we have SIMV. Then we have CPAP or spontaneous. So basically, it's how the patient's going to receive the volumes of gas we give to them. And basically what we're trying to do with the mode is meet their respiratory needs. We don't want to cause any ventilator-associated or initiated lung injuries. We don't want to impede circulation, or we don't want to make the patient discomfort. We're trying to prevent patient-ventilator dyssynchrony. So the modes, we're going to look at a little bit more breathing pattern, control type, and then a specific control strategy that goes with it. So again, your basic modes: controlled mandatory or continuous mandatory ventilation, assist control, intermittent mandatory ventilation, synchronized intermittent mandatory ventilation, and continuous positive airway pressure, okay? There's two control types we talk about with ventilators. One is called an open loop. This is the ventilator that's not the brightest ventilator in the world. If you want to make changes to it, you have to make the changes. You have to monitor your machine, make sure your machine is delivering the things that they need to be delivering to the patient. They need to make sure that if the patient's not meeting their needs, that somehow you can alarm or let you know that there's something going on with it. So you always have to check it, because the machine is not going to do this for you. Your closed loop ventilation, these are actually where you can set a parameter and tell the machine this is the parameter it has to meet, and the machine will then make sure that if the parameter is not met, that it's going to go ahead and kick in what needs to in order to meet that parameter. For example, if you set a minute ventilation of 6 liters per minute and the patient has been doing 6, 7, 8 liters per minute, which is not a problem, all of a sudden the patient, for some reason, maybe had a little bit of sedation or something, now has dropped down to 5 liters per minute. The machine's going to kick in either a respiratory rate or a tidal volume. It'll make sure that the patient is getting 6 liters per minute. Some of the names for these are servo. If you guys remember the servo wire from Therapeutics 2, where we talked about the feedback with the ventilator heaters, your Conchotherm, and things like that. This is the same principle. Set point's another one. So there's all different names that tell us that the ventilator can do this for us. So we have two operating modes. One is negative. This is mimic spontaneous breathing. This is your iron lung, your chest cuirass, the poncho. I'm going to show you some pictures of those shortly. Positive, this reverses spontaneous breathing. And the reason is we're pushing the breath in positively. And then this is the most commonly used operating mode. The negative one, here's your iron lung. The ventilator surrounds the patient's body. The air is evacuated. The amount of negative pressure is your tidal volume. Remember, with these, the head and neck are exposed. The problem with this one is that it can restrict the amount of care the patient's going to receive. Other things we see with it is tank shock. And tank shock is where the blood is pulling into the lower abdominal cavity, and then we need to work around that so that we don't cause problems with this patient, especially if we're taking this patient out to be able to do some care on them at that particular point. This is a picture of the iron lung. There's still countries and places where they do actually use this. This happens to be your chest poncho. You can see it's kind of comforting and warm and fuzzy. Chest cuirass for the most part. This is your turtle shell. They talk about that. It covers the chest only. Question that they asked on the boards one time was, how do you know that it's going to work? You basically make sure that you can put one hand between the cuirass and your body, and then you're going to go ahead and inflate it, and you should not have a problem. But the biggest problem with this is you still have problems with leaks. You don't have much of a chance for tank shock, but you may end up with that leak. All of the chest cuirasses are individually designed. It's not a one-size-fits-all. And there you can see a very comfortable machine also at this point. And there's a new one out, the biphasic cuirass. This is just showing this to you in case anybody ever should talk about you. I'm sure there's disadvantages with it. I'm not quite sure what they are at this point. But it does control your inspiration and your expiration at that particular point. And one of the things it talks about, it's considered a refinement of the iron lung. It expands the lungs, it generates a lower pressure inside the chest cavity than the outside, and that's where your tidal volume is going to come. You can see we have a lot of kids with those that are wearing those biphasic cuirasses. So what's the difference between pressure and volume? And some machines actually have both of these. Some of these you may set a pressure ventilation, but you have a volume assured. You may have a volume ventilation. You have something going on with the pressure also. But the clinical advantages of volume control, you have a more stable minute ventilation, better control over your ABG when your lung mechanics become unstable. Remember, volume ventilation, the definition of it is your volume is constant. Your pressure will vary. Because you have that constant volume, you have a pretty stable minute ventilation at that point. The clinical advantage of pressure control, patients have a tendency to like it a little bit better. Flow doesn't have a preset limit, and as a result of that, we don't see as much patient ventilator desynchrony. The newer ventilators, like I said, have dual control modes. We're always constantly trying to figure them out and figure out what is the best way to go ahead and make sure that our patient actually gets the best ventilation and the experience possible. So basically, volume controlled CMV, there's your precise minute ventilation. When we control the minute ventilation, we control your PaCO2. We also get more even distribution of ventilation with different time constants. This is something that you're going to talk about in 5th semester, but basically a time constant is how much time does it take to inflate the lungs and how much time does it take for the lungs to deflate. Okay. One of the things we're going to see is as the lung mechanics changed, we're going to talk about decreased compliance, increased raw. This will increase your peak airway pressure. Your peak airway pressure and volume ventilation basically means what's the highest pressure that's being used to deliver a breath. One of the ways that we try to control that pressure on volume ventilation is we set what we call a high pressure alarm, and we don't allow the ventilator to exceed that pressure alarm that's set, and that protects the patient and their lungs at that point. So the other thing we need to watch is make sure that we've set the flow appropriately. The flow has to meet the patient's needs. If the patient doesn't feel like they're going to get that flow, we're going to have that ventilator desynchrony, and then we're going to have problems with it. So regardless of the modes we use, monitoring of that patient is very, very important. And one of the ways we can monitor those patients is to watch and make sure that we don't see problems with them. Volume control IMV is mainly for patients recovering from sedation or rapidly reversible respiratory failure. What would be a rapidly reversible respiratory failure? Say you have a patient who comes in with an asthma exacerbation, his blood gases are pretty bad. We go ahead and put him on the ventilator. We go ahead and give him some sedation, a little bit of steroids, things along that line. And maybe in about 3 or 4 hours, sometimes they'll turn around and we're able to take them off the vent. And these guys really don't need, in some cases, a lot from us. We'll go ahead and give them a nice respiratory rate, a nice tidal volume. As we're getting ready to go ahead and try to get them off the ventilators, we're going to decrease the rate first. It does keep their tidal volume stable. It does control their work of breathing. And anytime you see anywhere 4 breaths or less, we're assessing this patient for weaning. So we still do use IMV or SIMV for weaning in some cases. So pressure controlled CMV, basically, we can use this with inadequate oxygenation. Part of the reason is that when we're using pressure control ventilation, we open up the alveoli much earlier. This is something when we talk about the inspiratory waveforms, we talk about the square wave, it does the same thing. It opens those alveoli much earlier. It increases the mean airway pressure, and we do get better oxygenation. We also get more even distribution of ventilation with different time constants and resistance. It stabilizes the tidal volume if you have an airway leak. And the rectangular pressure waveform, as we said, opens those alveoli and it makes the oxygenation much better for our patients. Okay. Pressure controlled IMV keeps this patient's spontaneous efforts and oxygenation. This is one that we normally use with infants. If we do use it, infants or adults, we need to decrease the peak inspiratory pressure, which is going to be the pressure that's set. That's your set pressure. Decrease the mandatory rate, and then prevent any volutrauma or hypoventilation at this point. And then for spontaneous ventilation, we do reduce the work of breathing, oxygenation for these patients. There's no muscle unloading. Remember, when we go ahead and put a patient on a ventilator, depending on the mode we're using, we will unload the muscles, and that's where we allow the patient to relax and be able not to have to concern about work of breathing. When we're starting to try to get them awake and do things with them, then we begin to reload those muscles. But on pressure control CSV, we don't have to unload the muscles because this is all spontaneous. It does help reduce some of the gas exchange problems that we have, so we do have to be careful with those. A low level of CPAP is okay, or we run into problems if we set high levels of CPAP. Problems with those will sometimes have alveolar overdistension, cause air trapping, and then we can also decrease the left ventricular stroke volume. So we're going to see hypotension and other cardiac issues that we really don't want to have to deal with. So for the most part, the clinical applications of these, it's volume versus pressure, volume control. Remember, we control the variables. We're going to set the minute ventilation. Pressure, not so much, but we're able to control patient ventilator desynchrony. You can see there's a number of different things below. These are the formulas that I'm going to teach you when we start to talk a little bit about compliance and resistance. With pressure control, we're going to maintain an adequate minute ventilation as well as we can. This is where the new dual modes come together. So it works much, much better for us. Our minute ventilation tidal volume is affected by the set pressure and the elastance resistance of the respiratory system. If we hit our pressure too quickly, we're going to have a decreased tidal volume. Like I said, the new dual modes are helping us maintain better control over this. We sometimes have a variable minute ventilations. Same reason why. The tidal volume is going to be your set pressure, your lung mechanics, inspiratory time, and your MAP increases, and then because it increases, we increase that PaO2. So what do we see next with our CMV or assist control? These are all machine breaths. Remember though, assist control has sensitivity. If we reach that sensitivity or the patient reaches that sensitivity, the patient's going to receive a machine breath. Disadvantage with this one, remember, is breath stacking. Breath stacking happens because of a time interruption. Remember, the patient can go ahead anytime they want during that total cycle time, hit their sensitivity and receive that machine breath. However, if they're too close to the set regular breath, remember the machine is going to deliver their breath right on top of whatever, wherever that patient's spontaneous breath may be at that particular point. It does provide a minimum minute ventilation for us. It does reduce work of breathing because we can provide full support to that patient. However, we also need to look at the trade-offs because sometimes we allow the muscles not to work as well as they need to because they're relaxing and resting, and it may interfere a little bit sometimes when it comes time to start weaning. So we need to watch times and the lengths of times patients are on the ventilators. And this is just a graphic just showing you at this particular point, there is no patient inspiratory effort. What mode can this be? This could be control. This could be assist control. This could be IMV or SIMV. In this case, if the patient is not breathing, the machine graphics and waveforms are going to look like that you're in some type of a control mode at that particular point. So in the next one, we're going to talk a little bit about IMV, SIMV. This allows the patient to go ahead and breathe spontaneously between those machine mandatory breaths. The difference is when is that mandatory breath going to be given? And with IMV, remember, we can get breath stacking. With SIMV, it's the machine's going to sense that patient's breath. They're going to go ahead and allow the window of opportunity, as I call it, to be completed. And then once the patient finishes their breath, if they come in and try to start another breath, hit sensitivity, the machine's just going to take that breath away from them and go ahead and give its breath at that particular point. Much more patient, much, to me in some cases it appears to be a little bit more comfortable. However, some of the research is showing maybe not. We do try to use pressure support with it. That seems to help quite a bit too. But be on the lookout. These are some modes that may be disappearing from our machines. But here's another graphic for you to see. As you can see the spontaneous breathing. You can see this where the little dash line is at that particular point. Let me grab my pointer here so we can see with this dash here. This is where breath stacking would occur. Here's the patient's breath. Here's they hit the mandatory timeline. There, in fact, now is the machine breath. We go back, as you can see, they went ahead and tried again. Guess what? They went ahead and banged into that same window. As a result of that, then they got another machine breath on top of their spontaneous breath. So CPAP, for the most part, or spontaneous, it's all patient. It's a very good weaning mode, and it is a mode of ventilation. Some people tell you it's not, but in fact it is. So other considerations, what do we have? Pressure control, pressure support, volume of support, bi-level pressure assist, proportional assist. There's your APRV, airway pressure release ventilation, that we're starting to see used quite a bit out in the community. Mandatory minute ventilation, I'm sure we still have that. We tried that at one time on an old Bear 1000 machine. Unfortunately, the machine and this did not work well. They're probably in the museum now. I have not seen any more in the hospitals, even as backup. Volume assured pressure support is another one, and then pressure regulated volume control is another one. So when we come and talk about full versus partial support, we can look at the work of breathing that goes right along with it too. And so remember, with full support, the ventilator does everything or most of everything. And it's controlling that work of breathing. It's also controlling, for the most part, your minute ventilation. And as you can see with this, that if you're IMV, SIMV, the patient is not triggering any breaths or just being very passive at that particular point, then they're going to have full support. Does it decrease oxygen usage? Yes, it does, because the patient's not really doing much and the machine is taking over for them. Partial support, the patient's going to share that workload. This is where you see IMV, SIMV, a little bit with pressure support. Can you have an increased oxygen usage in this mode with partial support? Yes, you can. If you have a patient who is trying to fit 20 breaths in between two mandatory breaths, that's a high respiratory rate on their part. That's a lot of work. And so we need to make sure that we go in there and try to keep that patient as comfortable and sedated so that we don't have problems with it. So the biggest problem we have is patient ventilator synchrony. If your patient and your vent are fighting each other, lots of oxygen's being used, there's not good support being provided, or there's too much of a wrong support being provided, and that's where we can see some problems with our patients and some ventilator-induced or associated lung injuries. So we have to keep an eye on that. Inspiratory waveforms, for the most part, this is how the breath is going to be delivered, okay? So when you're looking at your flow waveform is your inspiratory waveform. There's two you can see: volume control. You can look at the rectangular or square, or you can have a ramp, ascending, descending, or a sinusoidal. Today, the two that we use for the most part are what you see under pressure control, either the rectangular, which is also the square, or the decelerating. Which is more comfortable for the patient? Actually, the decelerating one is. Which one is going to provide probably the best oxygenation? That's going to be your square wave. Which one is going to have the least amount of increased pressure in the inner thoracic cavity? That's your descending or decelerating ramp. Which one is going to build up the most pressure in the inner thoracic cavity? That's your square wave. What do patients like? It depends on the patient. We've had patients that we put on a square wave. They did really well for a couple of days. All of a sudden, they didn't like it anymore. We went ahead and turned them over to descending. Everything worked out pretty good for them for a couple of days. And then sometimes they'll go back to the control or constant flow at that particular point. So it's really based on what is that patient comfortable with. So these are alarms. Alarms are very, very important. Alarms are needed to protect your patient. The thing about alarms, though, is we have so many alarms that go off in the intensive care unit that almost everybody in that unit begins to suffer from what we call alarm fatigue. So the question is, well, where are these alarms? How many alarms do you have? Well, think about it. You have alarms on your ventilators. You have alarms on your IV pumps. You have alarms on some of your other equipment like your balloon pumps. You have alarms with your feeding tubes. There's alarms everywhere. They actually did a study and they said if the alarms were set and delayed by at least 5 seconds, we would not have as many alarms going off and we would get beyond that alarm fatigue. I'm going to tell you, it's always important, if you know that your vent going off, go and check it. Because even if it's one of those alarms that basically self-corrects itself, you still want to make sure that that patient is safe. So alarms can either be about the machine or they can be about the patient. They can be visible, they can be audible, they can be a little bit of both. You have input alarms, you have output alarms, and then you have your control circuit alarms. There's hierarchies of alarms. The AARC has some specifically defined guidelines for ventilator alarms. There's now 4 levels of priority. Level 1 is your life-threatening one. And as a result of that, you definitely need to get up and respond to it. Some of the newer vents actually distinguish between the level 1, level 2, level 3, and the level 4 alarms. So you hear different sounds or different volumes for those. So you always want to make sure that you understand what's going on with it. Level 2 is something in between. You still need to get in there and check it out. Level 3, don't trip over a chair, but get up and see what's going on. And then level 4, this is entirely focused on what this patient is doing. That's basically a new category for it. Little ventilator alarm problems. They did this study, as you can see, between 2005 and May 2011. 119 patient deaths linked to problems with ventilator alarms. So what were the different reasons that were given for this? 16, because the alarms were improperly set or not used appropriately. 53, caregivers said the alarm didn't sound at all. Okay. But the manufacturer, if you look towards the bottom, tells you the alarm worked properly. However, the caregiver still said it didn't work. 4, the caregiver silenced the alarm. 5 or 11, they had no clue really what happened. It just sort of went off or didn't go off and the patient died. 27 of them, the caregiver didn't hear or respond to the alarm in time. Here's your alarm fatigue. 6 of them where caregiver wasn't sure if the alarm sounded, and only 2 ventilator malfunctioned. Okay. If you ever want to be in biomed and you want to work on ventilators, you have to carry a great big insurance policy because you're going to get sued until somebody finds out that you are not the problem. So if you look on page 991 in Egan's, he discusses all the different alarm levels and talks about 1, 2, 3, and 4. But I'm going to go a little bit over level 1. So question on what are some of the level 1 alarms? Power failure. This includes your battery backup. Remember, batteries only back up when you have them plugged in. If you hear your vents going off, you need to go in there and check them out. If your lights are flickering, that's a really good reason to go check your vents also. Apnea, absence of gas delivery. It could be that you've lost all your gas sources. At that particular point, if your patient's on a high FiO2 and you have no oxygen in the system, you need to figure out how you're going to deliver oxygen to them. Excess gas delivery. Remember, we still try to control the pressures in our system. Sometimes they don't work. Everything is man-made, has a problem with it. You have an exhalation valve failure, a time failure, you lose the battery backup, lose your different control circuits. The vents, for the most part, though, are very good about not letting you do something you're not supposed to be able to do. However, if the vent is not working appropriately, that alarm may still not alarm or cause some problems for it. In a ventilator that's failed self-diagnosis is not going to let you use it. It used to be at one time you could work your way around it, still use it, and then, call biomed and ask them to come repair it. Normally they would tell you as soon as you take it off the patient, let us know, we'll be down there. Nowadays, if you do not pass your test, your SST, EST, depending on the vent will not let you use it on a patient. So output alarms, for the most part, pressure, volume, flow, or time, inspiratory and expiratory gas alarms. High pressure alarms and low pressure alarms. These are really probably the most important alarms you need to set for a patient. High pressure alarm, I'm going to tell you, we used to do 10 to 20 centimeters of water pressure above what your average PIP is. It warns of increasing airway resistance, decreased lung compliance, what could set it off, biting the tube, a kink in the tube, water in the circuit, different things along that line. Low pressure, we normally set about 5 to 10 centimeters water pressure below the average PIP. It tells you that the patient's got a disconnect, or there's an opening in the circuit, or the cuff pressure is too low and now we have a great big leak around there and the volumes are much lower and there's a problem. We need to go in and take care of it. Other alarms, depending on the machines, not all machines have the same alarms, basically it's like 10 to 15% above, 10 to 15% below, whatever it is that you have at that particular point. When you look in EGANS, when they talk about alarms, they're not giving you the numbers like the 10 to 20 above or the 5 or 10 below. What they're basically telling you to do is whatever your hospital policy is, you probably want to go with that. A lot of the hospital policies, though, are written back when we did have these numbers, so just be aware that those are the way that we try to set them. Apnea ventilation, some people will call them the apnea alarms, doesn't really matter. Apnea is backup ventilation. That's backup ventilation to the spontaneously breathing patient. And the question comes in and says basically, well, why would you have a spontaneously breathing patient who stops breathing? Well, let's say something happens. Let's say that they perhaps had a stroke or something else that happened to them and they're now not breathing anymore. Let's say that they had a procedure done and they gave them some sedation, a little bit too much or for some reason, and so the patient's not breathing anymore. So what has to happen then, if you haven't set your apnea parameters, the patient's not going to get any breaths. So when we set these, what we do is we're going to deliver the predetermined tidal volume, respiratory rate, and normally FiO2. One of the fallbacks for FiO2 is if you're setting an apnea parameter, you want to set the FiO2 to 100%. Okay. Where do we set the tidal volume respiratory rate? Wherever it was set when the patient was switched from whatever mode they were to into the CPAP mode. So if the tidal volume were 400 mLs, the apnea tidal volume is 400 mLs. If the tidal volume was 12, respiratory rate rather was 12 breaths per minute, the apnea respiratory rate is set about 12 breaths per minute. One thing to think about, and this is what I tell folks, if you set that respiratory rate, say for example, we were doing something with the patient and the respiratory rate was at 6 or 8 or even 10, you don't want to put it that apnea respiratory rate at 6, 8, or 10 because there's too much time in between the breaths. So just leave it maybe around 10, 12, whatever you're comfortable with. But don't set anything less than 10 as your backup respiratory rate. You want to set these when you're setting up your vent and setting your patient up. Now, there are some new events out there that will not allow you to set the apnea ventilation if you're on assist control, simply because the machine is controlling everything. Once you take them out of assist control, then that apnea ventilation actually opens up. You want to make sure that you, in fact, go ahead and set that. Check those settings. There's been instances where people have not checked the apnea backup settings. They documented that they did. A case in point, some hospital, there was a lady who had really bad lungs. Her set tidal volume was 300 mLs. Nobody looked at the apnea parameters. That apnea backup was set at 900 mLs. She stopped breathing. 300 is a whole lot less than 900, and unfortunately she died within seconds of the second or third apnea breath that was given to her. So you always want to make sure you check everything. When you sign off, either electronically or on paper, that you check these different alarms, that's telling you that yes, you did it, and if something happens, you are liable for it. So your in-class assignment, outside assignment, this is for you to do throughout the day today. On page 995 of EGANS, there's 10 maxims for understanding different modes. And all I want you to do is go ahead and list them, and then just give me 1 or 2 sentences about the maximum that helps you understand it. I don't want any more than 1 to 2 sentences. Do not write a book. And then after you finish, just think about it. Is there anything that you think could help maybe clarify the maxims or be added to them? Or do you think there's anything that can be removed from the maxims? Kind of an interesting one to see where we are with the modes and with our definitions.